Good morning, good afternoon, and good evening to all our panelists and participants joining us from around the world. It is my great pleasure to welcome you to this roundtable discussion, which will take a deep dive into the private sector's involvement in digital care. My name is Dr. Muthoni Ntonjira, and I'm the Health Systems Country Leader at Philips Kenya, based in Nairobi. I'll be moderating today's session on private sector's involvement in digital health. Our goal for this session is to provide snapshots of the various areas in which private sector has played a role in shaping digital health for health systems by highlighting 3 different initiatives. We hope to learn from these experiences of our panelists about ways to strengthen collaboration between public and private sectors, and to understand better the enablers and barriers to the adoption and scale of digital health technologies. Digital health has leveraged in many different ways to address health system challenges and also to transform system delivery, with interventions that range from simple things like SMS alerts and reminders to improve patient adherence to treatment, all the way to complex strategies such as algorithm-based decision support systems for providers. Together with governments, the private sector has a critical role in playing to promote innovation and adoption, and also scale up of such digital health interventions. Today, we will dive into 3 specific case studies of digital health solutions that leverage public and private collaboration to address health system challenges in Rwanda, in Mexico, and in the Philippines. We will hear from 3 practitioners from the private sector and non-profit sectors who are working at the forefront of digital health to strengthen health systems. We're joined today by Dr. Siobhan Byamukama, most welcome, the Managing Director of Babil Rwanda, Rodrigo Saucedo, the Head of Digital Health at the Carlos Slim Foundation, and Anne Stark, the Head of Strategy and Innovation at Medtronic Labs. Our panelists will introduce the unique digital health solutions they represent before diving into a discussion on how private sector can more effectively collaborate with governments to strengthen health systems worldwide. And now, without further ado, allow me to conclude and introduce our first panelist. It is my utmost pleasure to welcome Dr. Siobhan Byamukama, who is the Managing Director of Babil Rwanda. As the largest digital health service provider in Rwanda, Babil is working with the Rwandan government to reduce the burden on health facilities and to improve access to affordable healthcare nationwide. Dr. Byamukama, over to you.
Thank you so much. First of all, thank you so much for inviting me to this important conversation about digital health. And it can't be more timely now. And the pandemic has shown us that, we've been talking about digital health for a very long time, and it's really, really imminent that it does have a space in the provision of healthcare services in any country in the world. So about Babil Rwanda. So first of all, Babil Rwanda is part of a global company called Babylon. We call it Babil in Rwanda, but globally we're called Babylon. And we started we opened our services in Rwanda in 2016, but as a global company, it was in 2013. So we started our services in the United Kingdom, where we're headquartered, and our mission is to provide accessible and affordable healthcare to everyone on earth. What better way to do it than starting from a developed country, and then a developing country, and then mushroom from there, because healthcare is a concern for everyone. Whether you're rich or you're not, healthcare is a concern for all. So we started our services in Rwanda in 2016. And our services ended up being slightly different because in every country, while healthcare needs are the same, the way of providing healthcare is different. And the first starting point would be from the devices that people have, because digital health is, people use their phones to access healthcare. So Rwanda specifically, while the smartphone penetration in Rwanda is only 15%, was only 10% actually in 2016, it's grown to 15% now. And we're looking to grow it significantly to about 35% in the next, couple of years. Currently, or when we started, it was only 10%, but phone penetration was over 80%. And that is the story of Africa generally. Phone penetration is really high in many places, and phones are used as a way of banking, as a way of transacting, as a way of doing so many things on the continent. So while our product in the United Kingdom was as a starter using an app, in Rwanda we use a USSD code. And so two things change in terms of the way we provide our services. Number one, we use a USSD code, but also number two, we have a call center. You don't take it for granted in many countries in Africa where to just ensure that everybody has a laptop, everybody has top-notch internet, so to control the ability to provide the care that you need in a quality manner, you have to control, the environment in which this sits. And that's why we have a call center in the capital in Kigali. We have about 130 doctors, about 230 nurses that work on a part-time basis to provide the care that we do provide. Why on a part-time basis? Because one of the challenges that we're trying to solve is the doctor-patient ratio, and you don't want to take away from the system the doctors for something that you're purporting to do as well. So we work with them on a part-time basis. They do work in hospitals, in private clinics, wherever it is that they work, or health centers, and in their free time, they do work with us. On every day, we do about 4,500 consultations on a daily basis, which is, which number has grown. And how do we use our services? We have a short code, *811#. You dial that number, you follow the procedure, you put in your national insurance number, you put in your national ID, and your national ID is supposed to be your primary identifier. So everyone in Rwanda above the age of 16 has a national ID. You put in your national ID into the system. We have integrated with a national data center where we quickly check in a second that this is the person that is asking for the consultation. We then check with the insurance company to make sure that you've quickly paid for insurance. So you have to put in your insurance as well. And then you book an appointment with us. When you book an appointment with us, at the end of the back end, we can see that somebody has booked an appointment with us. They have already done the insurance check and the identity check, and therefore a nurse is going to come and speak to them to see the number of to see what the patient is suffering from. In over 80% of the cases, these are consultations. Actually, the number has gone up to about 90% of the consultations that come through. These are conditions that we can treat, but there will be those rare cases that we can't treat, digitally, And so once we have done the consultation, because healthcare is an ecosystem, it doesn't matter what you do on treating the patient if you can't provide the laboratory tests, if you can't do prescriptions. So we have integrated with the government health facilities. There are about 106 health centers in the country. We have integrated with about 101 of those. And we literally went throughout the country to just check, does this health center have internet access? Does it have a computer? So can we put our portal? Have we trained them how to use our services? So that if a patient comes to us and does a consultation and they go to a health center, they're able to get the services that they need, which would be getting a lab test, getting prescriptions. So when you finish your consultation, if the doctor then thinks that you need to get a lab test, you'll get a short code, an SMS 16-digit code that you just take it to your health center. The health center will input that code and your name will come up with the prescriptions that we required or the laboratory tests that we required. And after those are done, they can be put back in the portal. They'll be visible on our platform. We'll call back the patient and complete the consultation. If we need the patient to get prescription, they will do that as well. So this is something that we have done for a very long time. And if you think about, in terms of the relationships that we have, with private sector, that would be with health facilities, with the Ministry of Health, which owns the health facilities, to be able to do the laboratory tests, to be able to do the prescriptions. In Rwanda, we have universal healthcare system where over 89% of the population uses the universal healthcare system. So we do have a partnership with RSSB so that when these people pick the prescriptions or the laboratory tests, those can actually be paid for by your insurance. So that the choice that you make is not I'm going to pay one for one service, but if I had gone to a primary healthcare facility, physical facility, I wouldn't have to pay for it. The choice is, do you want to go digital or physical? And that's the only choice that you make. The pay is the same. There's no change for you, so it's just a choice of digital or physical. And so we do have a partnership with, so that this universal healthcare system is under something we call the Rwanda Social Security Board, and we do have a partnership with that. The consultations are also paid through the same system, the consultations that we do. We also have another partnership with the same institution, RSSB, which is about 4% of the population in Rwanda, or 30 seconds left. What can I go to? What challenges are we solving? The problem that we're solving is that we have limited doctors in Rwanda. The doctor-patient ratio is about 1 to 9,000. So we provide ease of access so that the sooner you go and get your physical test and treatment, the earlier that you get better, so that you don't delay and then delay treatment. So that a $1 problem is a $1 solution, because once you delay to get the care that you need on time, then the $1 problem becomes a $10,000 solution or a $1,000 solution. So it's an easy and a way of accessing healthcare services when you need it, so that you treat conditions as they come before they get worse, which will be expensive for the healthcare system, which will be expensive for you as an individual, which will not let you have a healthy life and a meaningful way of contributing to your family and so on. Thank you.
Thank you. Thank you so much, Dr. Shivon. I know there's a lot more that you wanted to add, but time is a constraint. So we'll still have a session during the Q&A where you can add more details on the areas that you felt you needed to emphasize. Thank you so much. That was really interesting to listen to. Next, I'm very pleased to welcome Dr. Rodrigo Saucedo. Dr. Saucedo is the head of digital health at the Carlos Slim Foundation. Together with the Mexican Ministry of Health, the foundation is working to transform primary health centers through digital solutions that enable proactive prevention, detection, precision diagnostics, and evidence-based disease management. Dr. Saucedo, very interested to hear what you have to discuss, so the floor is yours. Thank you.
Thank you very much. Good morning from Mexico City. It is a pleasure to be here in this session hosted by the Digital Connected Care Coalition. As Dr. Nagonjira said, the work that we have done here at the Foundation, a nonprofit organization based in Mexico City, is intended towards tackling one of the most pressing public health problems here in Mexico and in Latin America, which is non-communicable diseases. The prevalence of diabetes, obesity, hypertension, chronic kidney disease in our countries are now representing the most burden of disease, and also they are costing a lot of resources for both Mexico's health system and patients who pay out-of-pocket expenditure to support the cost of these diseases. So based on these on this scenario, the foundation designed a public health model named MIDO, which means integrated measurement for timely detection. And MIDO's primary goal is to detect and tackle diseases from its early stages, and even take it a step further and diagnosing them when they are in a pre-disease stage, namely pre-diabetes, pre-obesity, pre-hypertension. And to do that, we developed a digital health platform. And this digital health platform works both online and offline, because even when connectivity is good in Mexico, we still have primary care clinics operating without access to internet. So it was very important to operate this digital health platform without access and not having that as a barrier to quality of healthcare. So Mido works on 4 steps. First of all, you have an outreach strategy in which you reach with the person. Then you perform some basic measurements, weight, height, blood pressure, blood glucose. Then based on this information, you build a specific risk profile. And based on this profile, you start providing some recommendations and some prescription on both non-pharmacological and pharmacological treatment in the case of people, of course, that need it. Up to this point, 2.5 million people have been assessed through Mido. And what we have found is pretty interesting. 8% of them were with pre-hypertension and 14% of them were with hypertension. Now, what's striking to us is that from those that were detected with hypertension, 58% of them were not aware of having the disease. And the same goes for people with pre-diabetes. 9.6% of the people had pre-diabetes and 12% of them with diabetes. And of those, 57% of them were not aware of having the disease. So what Mido really does is really performs timely detection to people who were not aware of this. And by tackling these diseases in its early stages, the likelihood of getting control and of course, getting a good quality of life increases potentially. Now, for those who already have a disease, there is another platform called SEEK, which is a non-communicable diseases platform. And in this, it's currently Mexico's official health information system, where currently there are 1.6 million people being assessed on a daily basis or on a periodically basis. And what's important in this platform is that it enabled the creation of 2 quality of care indexes in which we are monthly assessing the performance of primary healthcare clinics, regional places, states, and finally the national level. And we can provide timely recommendations. You can say personalized recommendations, tailor-made recommendations for these primary care clinics so that they can perform actions that can help them increase this quality of healthcare. So in sum, what we feel is that digital health is an enabler of personalized public health, meaning that you can actually provide tailor-made solutions to patients or to people living with the disease. And also you can tackle some barriers such as access and poor quality of healthcare services. Digital health really is an enabler and catalyzes a shift in the paradigm of healthcare. Thank you very much, and I'm very welcome to your questions later.
Thank you so much, Rodrigo. It was really nice to hear, you're coming from a completely different landscape. We're in Africa and we share so many similar health challenges. Yeah, so it's good to hear the solutions that you have. Next, I'd like to introduce our third panelist, Anne Stake, the head of strategy and innovation at Medtronic Labs. Anne will speak about Padayon, built through a partnership between Medtronic Labs and Reach 52. Padayon is a program that combines best-in-class technology, a tested curriculum based on behavioral science and excellence in local implementation to help patients achieve health outcomes. Thank you and welcome. The floor is yours, Anne.
Thank you so much. And thanks to the other panelists. I feel like there's so much that we have in common. So looking forward to the question and answers and following up later. But first I want to start off describing what Medtronic Labs is and then get into Padayon, but more as perhaps a comparator to a lot of the other work we're doing in 10 countries at Medtronic Labs. So Medtronic Labs is an independent nonprofit organization funded by Medtronic, so a completely separate legal entity focused on expanding access to healthcare for underserved patients, families, and communities across the world. And digital health is one of our strategies, but not the only strategy that we employ. So we have 3 kind of core elements to our work. One is, of course, digital health and digital solutions designed for patients and for community health workers and for health systems, with the goal of kind of full integration into public health systems in the long term. The second is around hyperlocal field operations. So building teams on the ground that are embedded with the health systems that we support. And then finally, the third pillar is implementation focused partnerships. So partnerships with ministries of health, with faith-based organizations, with partners like Reach 52 in the Philippines, et cetera. And right now we work in, I was saying, 10 different countries, including a recent launch here in the US, bringing a lot of the same elements of digital health here. So we work in Kenya, Ghana, India. Those are our biggest programs, but expanding pretty rapidly. So Padayon in the Philippines actually started in India with a program called Prerna. And similar to, I mean, some of the elements that we were talking about in India, 80% of healthcare is provided in the private sector, high fragmentation. We were at labs, Medtronic Labs, were primarily focused on non-communicable diseases, similar to Rodrigo, because as we know, 1% of health spending goes to NCDs, and yet it's 70% of the mortality rate across the world. So we started looking at hypertension, diabetes, pre-hypertension, pre-diabetes in India, and tried to understand how we might be able to actually get patients to a measurable clinical outcome. So we weren't starting with the technology, but rather starting with the patient and designing from there, and then from that perspective. So we assembled a group of 40 community members that were living with diabetes and hypertension, actually co-created the model with them. So what ended up coming out of it at the end of almost a year of research on the ground and co-creation was a program that's group-based. So it's a group-based service delivery model where we screen patients similar to what Rodrigo was talking about for hypertension and diabetes in the field using point-of-care diagnostics and community health workers or health coaches. And then based on their risk profiles, we assemble them into groups where that becomes the center of their care. And we have developed a curriculum with the patients that we're working with that integrates both social and clinical dimensions. So of course, we take all of the lab tests. We connect the group with doctors via telemedicine and or in person in some cases. We provide remote coaching, but we also, on the clinical side, but we also do quite a bit of work on the social determinants. So on healthy living, on exercise, on diet, and use a lot of strategies built around the local context. So for instance, in India, we focus quite a bit on tea, et cetera. And the technology part in this program is really an enabler. And the way it evolved was during COVID. We actually were looking at how we could expand this model because it was doing really well in India, to the Philippines or to another country. And through a conversation with Reach 52, realized that there is an opportunity to expand that through a local partnership since they already have active networks. So we ended up working with them to essentially adapt the model in the Philippines or in the model in India to the Philippines context. And now we're actually expanding the same model to Cambodia as well with a larger consortium of partners. So what started as a very small initiative in India has expanded to multiple countries in Asia. And one last thing before I pause is that this is a little bit of a different approach that we've taken in Asia as compared to some of our work in Africa. In Kenya and Ghana, and other countries where I work on the continent, we've found a lot of success working directly with ministries of health and large health systems. So our approach there is really addressing hypertension and diabetes alongside ministries of health and really embedding our digital health solutions into health systems and kind of co-evolving with ministries. Although a lot of the same elements are still present. So peer support groups, the ability to connect with telecounselors. We have a call center as well. So we see tech as really the enabler of patient outcomes and kind of system transformation. Thank you.
Great. Thank you so much, Anne, and I think you've shed a lot of light, though I know that time is limiting, but we'll come to some of the questions that are coming in. I'd like to open the roundtable discussion, and please, if you do have a question, type it into the chat box. But I'll first begin with just asking a few questions to each of the panelists, just to focusing on the effective cross-sector collaboration for digital health. And my first question will go to Dr. Shivon. How did Babil navigate building relationship and trust between the government of Rwanda with what was needed to deploy digital health services, the digital health services that you provide, and what challenges did you face along the way? I know you got a little bit into the challenges before time ran out. Maybe you can give us more detail on that.
Okay, fantastic. Thank you so much. So maybe let me start from the place of, so Rwanda, I think as a strategy of the country is a sort of proof of concept country. They encourage businesses to come, try their businesses, and if successful, then they expand to other places throughout the continent or wherever it is gone. And there are a couple of other companies that have actually done that. So there'll be some sort of support that you know, sort of like they want to listen to ideas and see, especially technology related ideas, to see where that where that goes, because you know everybody knows that, you know, sort of like, especially in the developing world, sort of like leapfrog into the future is, you know, through use of technology. But it doesn't mean that then they're open arms and saying, come try your ideas, so here is a silver platter for you. They're very cautious, you know. One of the things that, of course, that we saw even from the beginning was even looking at like the scope of services that were given, you know. We began by even not treating like actual conditions, but like symptoms. Let's try this for 6 months and see what it is that you're doing. Let's give you a license for an additional 6 months. Now let's give you a license for a year. And over time, we started getting like an expanded license. So since 2016, our license has been expanding over a period of time. Now it's a much bigger scope of services that we do, but it took time to get there and to walk, you know, the journey with them. And then also the other thing is that, I guess, if it's a product that is needed, that will be impactful, that is something that will be welcoming. In terms of challenges, lots of challenges, like even us changing our product to be a USSD platform. These are things that we realize that, oh, we can't cut and paste. We have to come and change our product and see whether it works here. Then also maybe one of the things, because you're asking, you know, how did you navigate? Is it takes a bit of time to sort of like understand who is saying what, because when you say government, what is government? Is government the payer? Is government the Ministry of Health? Is government the RDB? Because everybody, you know, there's a whole range of government, and you know, and everybody has competing interests. For example, the Ministry of Health is like, great, this is going to help us with the doctor-patient ratio, this is going to help us, but let's think through the conditions that you can treat. But okay, let's give you health centers that you can work with and then test this idea with you. That is one, but they're not the ones paying for the service, because now the payer is a different government, right? Then that's another person that you have to contend with and then deal with it. And then when you are coming in, the person that lays the carpet for you, sort of kind of saying, come try your service, that's a different institution altogether. That institution is not the payer, it's someone who's like encouraging investments. So that comes in, and then there's so many, and it takes a bit of time to sort of know, who am I dealing with? And one of the things that we have learned over a period of time, because we've been here since 2016, so we've sort of like navigated our way through. One of the things is just understanding that when you're speak one voice with all of, you know, can we understand all your competing interests, and can we, you know, because otherwise it's very, if you're coming in as a new person into any country, and then people have competing interests, and people are giving different direction to things, then it can be so confusing. So having sort of like a convener to kind of say, but who is government? Can I speak to this government? You know, like, even if it's not the minister, it's, you know, maybe 2 notches lower, but can I speak to all of you? Can we then start having that conversation together? And I think that we would have achieved a lot more had we known that,
Yeah.
you know, that's a lesson that we have learned.
Yeah.
So yeah, that's maybe an insight I would have wanted
Thank
to
you.
share.
Thank you. I'm seeing the questions are coming in, and I want to quickly jump to Rodrigo. To just briefly, in probably 2 minutes, tell us how the Carlos Slim Foundation and the Mexican Ministry of Health was jointly able to lay groundwork for scale up and sustainability of the CaSalud model. That'll be very interesting before we jump into the questions from the participants.
Sure, thank you for that question. I think what was important is that we started from a bottom-up approach. So we first tested the model with primary healthcare clinics, with regional and state authorities, and we built a solid body of evidence in which we demonstrated both the feasibility and the benefits of scaling these solutions. So based on that, we convened the partnership with the Ministry of Health, and we started a very phased scale up. We didn't really jump in from scratch to everything. We did it on a face-to-face approach, and it took us almost a year to get where we were at that time. And since then, it has been a matter of really being open and transparent and understanding their leadership and validating their leadership in the operation of these solutions, and from us providing both the technological and analytical support, and of course working continuously in the development of new solutions or refined solutions to continue strengthening this model.
Thanks for that, and very clear. Coming to you, Anne, just briefly, how do you feel? What were the successes that Padayon was able to realize early on by combining expertise?
Yeah, thanks. I mean, I think clearly we were able to piggyback on a lot of the operations that were already existing through Reach 52 on the ground in the Philippines. And we were able to bring our model that we developed in India and combine those two into a working model within, I think from start to finish, it was 2 months where we launched. So it was really fast. But I do want to respond to something that Dr. Shivan said, because I think it is really resonating with me around, you know, some of the lessons that we've learned in all of our work in our 10 countries. And I think had we also understood how to engage with the ministry more effectively from the beginning, we would have been a lot more successful. And I think we're just starting this journey now. But to her point, when you're talking about a government, there's like 10 different people that you need to engage with, whether it's the e-health department or the health IT department, or, you know, there might be someone else working on the national EMR. There might be a division that's focused on NCDs, and you have to bring all of the different partners together. And the key lesson here for us is that proximity at every level of the system, from the patient to the community health worker to the doctor in a rural health center, all the way to all the different technical working groups that are happening, is absolutely key to understand, you know, who's saying what and what stage is the digital health ecosystem at, in order to meet that ecosystem where it is critical. And that's been consistent across all of our programs, Philippines, Kenya, etc.
Okay, and I'll stick with you, Anne, because there's a question here from Sinthwani, who's, first of all, an interesting model and great work. What were some of the challenges you faced while implementing the model in India? How did you ensure adherence of prescriptions?
Yeah, I think one of the main challenge in implementing in India is really the high fragmentation that I alluded to at the beginning. So the Indian health system, where 80% of healthcare delivery is private, is highly fragmented. So in order to, you know, build momentum, we had to figure out how to access a large pool of patients and build trust with those patients. We ended up looking at partnerships with a lot of different entities, whether that was microfinance institutions or large employers, in order to, get some entry point into that population. In terms of adherence to prescriptions, that was all part of the curriculum that we've been working on. So we spend quite a lot of time on educating patients about like the long-term risk and the importance of adhering, but also the idea that it's not just you take a pill once and then you start to feel better and then drop off, which was what we saw happening. So we integrated all of that education and then combined it with SMS reminders. If we do see patients aren't refilling their prescriptions on the platform, we're able to send them immediate SMS reminders to refill their prescriptions. And then we follow up with a telecounselor call as well to make sure that we understand why.
Okay, perfect. Thank you. Thank you for that. I'll move over to Dr. Siobhan, and the question here, sorry if I can quickly get to it, is again from Synth. One quick question: how is your model sharing data with your government, especially on population health? Sorry, I think I have skipped. Just let me scroll properly. Sorry about that. Let me open it up properly. Keeps moving from one to the next. So yeah, sorry, to you, Dr. Siobhan, how is your model sharing data with government, especially on health, population health analytics?
Well, thank you for that question. So we have something called HMIS, and the government, Ministry of Health particularly, has asked us to fill in information. And this is data on what are the conditions that you're treating. It's really aggregated data into how many malaria cases, how many whatever, where is this located, and everybody throughout the country is doing the same. So we provide that information. Hospitals, health center, everybody provides us and inputs this information into the HMIS. And I think that that is how the government is able to sort of like analyze, sort of like the disease trend and so on in the country through this HMIS data that they do have. We also share information, but we of course do have a data sharing agreement with the insurer, because sometimes they want to understand things like what conditions are you treating, sort of like a verification and pay, the sort of payer pain and so on. But I think your question was more in how do you share analytics with government, and I think that is through aggregated data, no patient data, just aggregated data on terms of how many cases of malaria, how many cases of this, whatever, so that we can also see the trends. We also do our own internal analysis to sort of say these are the most conditions that people, call into. These are the ones that are more prevalent in this place over this place. So we do our own analysis as well in terms of aggregated data. Thank you.
Okay. Thanks for that, Siobhan. And for the last question coming in from Kwasi, I think it's a question that will be addressed by all the panelists because it cuts across. And maybe to start with Rodrigo, how do you address increased safety and security concern that come with data and increased connected health solutions?
Thank you. I think that's a very important question. I could say that question has different answers depending on the end user, but first of all, we work on health information exchange guidelines in which you establish the security protocol and the type of information that you want to receive. On the other hand, you have different types of users which have access to different types of information. And of course, this is a very important responsibility because you're having access to health data. So you have to make sure that you understand who your end user is, and that they are also very aware of the type of information they are accessing. At the technological and the infrastructural level, you have the different strategies in which you, first of all, you make sure that you're either the cloud in which these solutions are hosted or the servers, they are secure ones. We're constantly running different tests so that we make sure that we're not vulnerable to cyber attacks. And of course, these platforms are constantly being updated to reflect advances in security, and that to make sure that our solutions are safe. And I think it all comes to having best practices and to being systematic in the way that you develop and operate these solutions. so that you can build trust with your partners, so that they can trust these solutions.
Okay, thanks for that. Anything, Siobhan, you'd want to add from what Rodrigo has discussed on the same topic?
I'd like for Rwanda, we now have a new legislation that has come into place, and it's really for protection of patient information, so privacy of information. So this has been really welcome, and everybody is going to be able to comply. They've given a period of, I think 18 months to make sure that every company complies, and there's stringent measures against that. I think this is very welcome, because while obviously as a global company, we have been very, we follow, so that's the legislation here in Rwanda, but as Bubble, we follow the, like if a legislation is applicable in the UK, in the US, in anywhere else, as a global company, that then automatically applies to us. So it's very good that while we do have the systems in place to make sure that, patient safety is a priority, in terms of their data is a priority, the Rwanda legislation is also going to even make that voice even harder. All the information that we share is basically aggregated data, and if it is not aggregated data with one institution, which is, for example, RSSB, we do have a data sharing agreement, and at the beginning of every consultation, we do inform the patient that this information will be shared for purpose, and indicating the purpose. But as a base role, we don't do share patient data at all, which is currently all stored in country.
Okay, thanks for that. And anything else you'd want to add on data security?
I think Rodrigo and Dr. Siobhan outlined it perfectly. I would say we share all of the same commitments to data privacy and security, the same best practices, compliant with GDPR, HIPAA, and all the local regulations. I think Dr. Siobhan did pick up on something that's top of mind for us, which is the fast evolving regulatory environments in all of the countries where we work, which is welcome, because it helps us adapt to all of the local regulations, and makes it a lot cleaner and more clear for all of the different digital health innovators in the country. So yeah, I think top of mind, super important, probably the most important question.
Yeah, absolutely. And of course, during this COVID-19 pandemic, it goes without saying that we have to mention something about it. And just looking at probably in 60 seconds from each or even less from each one of you, starting with you, Anne, has there been any impact in terms of adoption and scale of digital health during this pandemic period?
I think that I'll echo probably what a lot of people have said already, but I think COVID-19 and the pandemic has further strengthened the case for digital health, has accelerated the adoption. And I think for us, this is a huge opportunity to work towards, a more equitable digital health enabled system.
Yeah. Thanks. And on your end, Siobhan, any impact? Has it helped in adoption, helped in scale up?
So when COVID hit in Rwanda, which was about March 2020, and if we looked at the trajectory of March to May 2020, our numbers grew by 155% of people calling from home. Because suddenly, there was lockdown throughout the year, there was, throughout, different periods, but also the importance of realizing what digital health does. So we were almost like COVID ready. So when COVID hit, we were already everywhere in the country, we were already doing digital services. So it was really doing more of the same, but people really adapting the services that we do. Over and above that, I think we did play a role in supporting the COVID pandemic, because when people were quarantining at home in Kigali, the government gave us all those patients to look after. So we called you every single day if you're a COVID patient. We called you every single day, made sure that you have you're feeling well. And if you needed prescription, we would be able to send you that prescription and so on. And only in very few cases did we have to to take care of you so that you don't overwhelm the healthcare system, which was already struggling at the time.
Thank you. And Rodrigo, just in 30 seconds, since I see we're already out of time.
Yes, of course. I think I already agree with what Anne and Dr. Siobhan said. I would only add that digital health evolved from being a luxury good on being a basic good in this pandemic. And the value of digital health was finally demonstrated to the decision makers all around the world. So hopefully this so-called trend is now the new standard in public health. So I'm very happy that we're finally moving on into that next stage.
Yeah. Thanks for that. And I want to sincerely thank all of you for very rich discussions. This has been very insightful. I mean, looking through the solutions coming from Rwanda, looking at what you're doing with NCDs in Mexico, looking at what Medtronic Labs with Reach 52 is doing in the Philippines. I mean, looking across those health systems, it's been fantastic to see the solutions that are coming up to strengthen healthcare, and also seeing the dynamic environment that you're already adapting to. So thank you so much for that. We have unfortunately reached the end. Good things come to an end, unfortunately. So we've come to the end of this webinar. I want to sincerely thank all the panelists, the audience members for your participation, sharing those questions, for your attention, and also for joining in the session. Thank you so much. It's been a very interesting discussion, and do keep safe, take care of yourselves, and have a good evening, good night, good day. Bye-bye.
Thank you. Bye-bye.
Thank you very much.
Thank you.
Bye-bye.